Good afternoon, and welcome to the Radiology Today webinar, the latest clinical trends in cardiac CT and MR. We would like to thank our program sponsor, Philips Healthcare, for supporting today's session. The Radiology Today audience has been eagerly anticipating today's presentation, and we have a wonderful faculty. To get us going, it is my pleasure to introduce today's moderator, Kevin Lev, Marketing Director for Advanced Visualization and AI Solutions at Philips. Welcome, Kevin.
Thanks, Jack, and it's a pleasure to be here, and I welcome everybody who's had the chance to join this presentation. We're very much looking forward to sharing some insights in cardiac CT and cardiac MR. I have the pleasure of being joined with two physicians that we work very, very closely with and are experts in the field, Dr. Tim Leiner and Dr. Jonathan Leipzig. And we'll be handing off the presentation to them just after we've had the opportunity to share with you a couple of our insights for how it is that we view the world of cardiac CT and MR from an advanced visualization perspective. So in just a couple slides, we'll just be doing that. Just to give a sense of how it is that we view cardiac CT and MR in the world and the challenges that we face in the world of advanced visualization. Part of the key issues is that what we'd like to be able to do is to continue to provide a high level of intelligence, depth of analysis, and that can be done with a host of different advanced visualization tools that we have within platforms like the IntelliSpace portal. Those that help support diagnostic confidence by providing accurate measurements, measurements that are in line with what we need in order to be able to provide a holistic diagnostic for the patient. And also, while doing that, what we'd also like to do is not enhance the time that it takes to be able to provide that report by automating as many of the steps as we can along the way, either by automating the analysis or actually taking physicians through the steps step by step to make sure that we have all the details necessary to complete the report and automating the reporting process as much as possible. And those are some of the features that we have built into IntelliSpace Portal version 12, which hopefully we'll be able to launch at this upcoming RSNA in just a couple short weeks. But the way that we try and look at the cardiovascular continuum of care is to look at it very holistically. It's not only to provide a couple different applications, but to provide a host of different applications in various different disease states, but also across screening, diagnosis, and treatment planning and follow-up, so that there is a clinical application that can be useful or handy no matter what the patient is suffering from and no matter where they happen to be along the continuum of care. Again, trying to provide depth of insight, but also automate that at every step along the way. With our latest version of the IntelliSpace portal, which again, hopefully we'll see at the RSNA this upcoming couple of weeks, what we've done is added a host of new applications, such as photorealistic rendering, and then also cutting-edge capabilities like 4D flow and strain, while also enhancing core applications that we have that have been useful for our clinical community for quite some time now, whether in vessel analysis or comprehensive cardiac care, calcium scoring, or even beyond with MR cardiac and spectral imaging as well. And this really speaks to our commitment of being able to provide new innovation, but also to continue to enhance our core platforms with the feedback that we get from our customer community, from our clinical community, and also to continue to refine those capabilities to provide more insights each and every step along the way. Two applications that we have enhanced in particular are those that will be touched upon hopefully today in the presentation. One is through our MR cardiac, which we've actually enhanced with significant amounts along with other applications within our portfolio with artificial intelligence to be able to do things like right ventricle and left ventricle automated segmentation and for functional analysis that greatly allows us to be able to speed up the time that it takes to get to quantitative results to less than 20 seconds. At the same time, we've also enhanced our CT comprehensive cardiac analysis application that allows us to be able to do things like robust automatic coronary tree and extraction, be able to pull out up to 17 different coronary segments, and we've made it optimized even for low dose CT as well. All of these enhancements and more can be seen when you have the opportunity to request a demo at the RSNA for these applications. And now what I'd like to be able to do is to hand off to today's speakers. The first speaker that we're going to hear from is Dr. Tim Leiner, Professor of Radiology, who also holds the chair for cardiovascular imaging at the Utrecht University Medical Center in the Netherlands. After that, we're going to be hearing from Dr. Jonathan Leipzig, who's the chair of the Department of Radiology for Providence Healthcare at Vancouver Coastal Health in Vancouver, BC. I'd also like to remind the audience that if there are any questions, you can always put those questions in the chat box. We're going to leave enough time at the end of the presentation so that you can hopefully hear from the questions that are coming from you, and we'll hopefully be able to answer those questions with the panel of the two distinguished speakers we have today. With that, I'd like to pass off to Dr. Leiner to hear about how it is that we can hear about the capabilities of advanced visualization in cardiac MR and trends in that space. Dr. Leiner?
Thank you, Kevin, and good evening, everyone. At least it's good evening for me. Good afternoon if you're in the United States or across the ocean. So this presentation is going to be about advanced visualization in cardiac MR and the current trends and needs. So I'm a cardiac radiologist, and I read cardiac MRs and CTs every day. And in this presentation, I'd like to share with you some of the thinking I've been doing and some of the trends that I've seen in the literature in this space with regard to quantification and visualization. So these are my disclosures on this slide. And in this presentation, I basically want to make the case that there's a need for precise quantification in cardiovascular MR. And I want to make this case by illustrating this with clinical examples of the added value of using these quantification tools that I'll be discussing and these different clinical scenarios. So let's jump right in and look at the need for precise quantification. And there are many reasons to do this, but I'll give you a couple on this slide. So one of them is that in clinical practice right now, we use standard nomenclature that is, although standardized, it's relatively imprecise. And most of it is based on simple visual analysis. For instance, if we look at wall motion abnormalities in cardiac MR, we have a very simple system to describe this, and it's hard to learn to apply this. And as a result of that, there's a lack of agreement between observers, especially if they're more junior. So we need better tools there to just precisely quantify this. So the second reason for quantification is that management of patients with cardiac diseases is increasingly based on precise cutoff values. For instance, the decision to implant, let's see, the presentation now jumped. I have another presentation in front of me right now. Sorry. Let's get back to the slide that I wanted to show you. Okay. Yeah, okay. Standard nomenclature is imprecise, lack of agreement between observers. So yeah, the decision to implant an ICD is something that's done based on the left ventricular ejection fraction. So we have to precisely measure this in order to come to a decision whether or not to implant the ICD. What we also want to do here is to precisely quantify scar tissue in the left ventricle, for instance, to support this decision. So another reason for precise quantification is that CMR contains a lot more information than we currently use. And what we do is we have a very good tool, a cardiac MR scanner, that allows for high fidelity depiction of cardiac anatomy and deformation over the cardiac cycle. But as mentioned before, we don't really leverage this information because we have very coarse and imprecise language to describe these findings. And making precise measurements will refine the assessment of this. The second point here is that there's more information than we're currently extracting as human observers. For instance, an example of this is the analysis of grayscale values, also sometimes called radiomics. This is advanced analysis of grayscale values in the images where quantitative parameters can be extracted that can be very helpful in clinical practice, which I'll show you later in the presentation. And the final reason is that there's a trend also in MR to 4D acquisitions, where in retrospect, we choose the plane that we want to analyze or the specific cut of the tissue that we want to visualize. So these are some reasons where precise quantification and visualization are very useful for. And in the remainder of the presentation, I want to illustrate these points with specific examples. So the first example that I want to show you is machine learning-based quantification of ejection fraction. So Kevin already touched upon this in his introduction. And this paper that recently came out basically shows you that this technology is now really ready for clinical practice. There's very good agreement between manual segmentation, as you can see in the left graph, and the left ventricular ejection fraction as calculated by machine learning techniques. The correlation coefficient is very high, the differences are very low, and the errors are basically not clinically significant anymore. So this is now really ready for clinical use. And in addition to allowing for precise quantification, it also allows for much faster analysis of the images. So basically, when the radiologist or cardiologist opens the scan, the results can be already present for extraction and being put into the scanning report and the radiology report. So the editorialist who reviewed this paper notes that this is strong evidence for the value of this technique. This was a study done on many different MR scanners in different institutes in 400 patients. So that's a very strong point. Normally this requires up to 10 minutes or so, but now it's done in less than 1 second. So I think this is one example of where advanced quantification really helps you to increase your efficiency, but also reduce the inter-observer variability. So let's move on to the second example. That's myocardial deformation imaging. I already touched upon this in my reasons for why this technology would be useful. And increasingly, we're seeing people measure strain in cardiac MR images. Now, for those of you who are not familiar with this concept, this is a very good publication that explains this technique in great detail. So if you're interested, note the reference in the left lower corner of the slide. And basically what we do with strain is we measure the deformation and we quantify this. So we have the longitudinal strain, which is the shortening of the left ventricular chamber over the cardiac cycle. We have radial strain, which is thickening of the myocardium at a specific point. And we have the circumferential strain, which is the basically the twisting motion of the heart, and this can also be quantified. So these are three different components which can each individually be quantified and to measure deformation of the heart. Now here are a couple of ways that you can do this. So in this movie, so Jack, if you can please start the movie, you can see the software working. So what you will see in this image is deformation of the left ventricle. You can see that there's wall motion abnormalities in this patient. And instead of describing this in words, you can now precisely quantify the deformation of each different segment of the heart in different anatomical orientations. And this can then help to quantify the severity of the deformations. So this is based on images. It can also be done using dedicated sequences, which are working with raw case-based data. And an example of that can be seen in this movie. So if you can please play this, Jack. And what you measure when you run the sequence. So when we move on to the next slide, I'll show you some evidence of the added value of this technique. So this paper was very recently published in JACC Imaging. And what it shows is evidence of the value of feature tracking measured global longitudinal strain for predicting outcome in patients with preserved ejection fraction. So normally we would use the ejection fraction as the primary measure to quantify the myocardial function. But in this study, the investigators showed that if you have a normal ejection fraction, but an abnormal strain, this technique is capable of adding prognostic information. So I expect this to come into clinical practice very soon. Primarily, this is done with echocardiography, or in echocardiography, this is long known to be a valuable technique, but now it's also available in MR. And the information is there, so we just need to extract it and put it in our report. In the next slide, this is another way of looking at that data. So if you have normal global longitudinal strain, i.e. values of, let's say, approximately 25%, you can see that there's a low risk of an adverse outcome, but this goes up rapidly if you don't have enough shortening of the left ventricle over the cardiac cycle. Hazard ratios go up to between 5 and 20 times. So this is a very strong predictor of adverse outcomes, and therefore we should be measuring this in every patient. The third example I want to show you is particularly relevant in the current era, and this is the abnormalities that we can see in patients who have or had COVID-19 disease. So this has also been studied intensely in the literature, but I'm just going to pick out this paper right here that was also recently published. And it looked at cardiac involvement in patients recovered from COVID-19, which were assessed with cardiac MR imaging. And the point that I want to make here is that traditional sequences like edema-weighted sequences can visualize enhanced myocardial water content, and PSIR sequences can identify focal scar tissue, but using parametric mapping, we get a much better overview of the extent of the damage that COVID has done in the heart. And we can see areas with a lot of abnormalities on the T1 maps, the T2 maps, and the extracellular volume parametric maps. And if we look at the quantitative data in this paper, you can see that these parametric maps are the ones that really are different between patients who have conventionally positive and negative MR sequences and controls. So this is a very strong reason to incorporate these mapping tools into your MR scanning protocol. So the fourth example I want to discuss is 4D flow. This is an example of a technique where we basically acquire a volume of data and then retrospectively analyze this data by slicing and dicing the imaging volume. And for those of you who are not familiar with this technique, I want to show you this video. So Jack, if you can please play this video. What you see here is a coronal reformation.
Dr. Leiner, just to be clear, we lose the audio during the video play, so maybe just to let note what the audience is seeing during the video, we'll let the video play, and then once the video is paused, so we can get back.
Okay. Can you pause the video, Jack?
Yes, video is paused. You can tell them what we're about to see, and then I will launch the video for the audience.
Yeah, okay. So the what you will see in the upcoming video here is a coronal reformation of the large vessels and the heart and the chest, and the gray box represents the volume over which we acquire flow data. So if you can play the video, Jack. Yeah, thank you. So then we move on to the next slide. And what we see right here is a visualization of the information that is obtained with such sequences. So what we can see right here on the left is a visualization of flow through the tricuspid valve and then into the right ventricle and the right ventricular outflow tract and the pulmonary artery. And on the left side here, in the right part of the slide, you see a normal pulmonary artery and left and right pulmonary arteries after the bifurcation. with different parameters that can be calculated, such as the velocity or the energy loss or vorticity formation in the pulmonary vessels. And you see that this is very low in the normal situation, but in this patient on the right side here, with a repeatrology of fallow, you can see that there is massive abnormalities. The vessels are dilated, and you can see that these there's a lot of vortex formation in the flow pattern and a lot of energy loss. So this particular anatomy is very inefficient for transmitting the blood into the pulmonary circulation. And this is shown in more detail in this video right here. So if you can play this, Jack. Thank you. We'll move on to the next slide. And this tool is now also available, as Kevin said, in IntelliSpace Portal. And this is a collaboration with Kaas from Maastricht, the Netherlands. So what is the value of 4D flow imaging? Well, that's, in my opinion, for instance, measuring flow across all valves and valve tracking over the cardiac cycle in comparison to 2D flow, where we normally have a fixed plane and we always have errors of 10 to 15% between stroke volumes in different vascular beds and across the valves. So this really helps to reduce that difference and make the numbers more reliable when quantifying flow. So this study nicely showed this in 114 patients with acquired or congenital heart disease and 46 volunteer control subjects. And it showed that the quantification using the automated system is pretty well comparable to the fully automated quantification. For instance, if you look at net forward stroke volume variation, this was significantly lower for automated analysis versus human analysis. All right, so the fifth example or set of examples that I'm going to discuss before we finish up the presentation is leveraging unused information. And there are several examples that I want to show you that, in my opinion, are highly valuable illustrations of this concept. So one of them, the first one, is this paper that was recently published in Radiology. And what these investigators aim to do in this study is they try to use texture analysis instead of gadolinium enhanced imaging to detect scar in the left ventricle. So they used quote unquote radiomics to try to see if they could extract the presence or absence of scar in regular cine images. And for this, they studied 120 patients with scars using cine imaging and LGE, and LGE, late gadolinium enhancement, served as a standard of reference. 72 patients had large infarcts, 48 had small infarcts, and 60 control subjects were studied. So what they did is they took an open source texture analysis package called Mazda. You can download this for free from the internet. They measured 286 features that quantified relationships between the pixels, so the grayscale values that you measure in the image, and they just ran this on a standard PC. What they analyzed was a single end diastolic frame of the cine sequence, and they also looked at reproducibility. And the interesting thing is that if you look at the ROC curves, you can see that several features were capable of detecting the scar with a reasonable degree of accuracy. It's not perfect, but what this shows is that there is signal in these images that you can use to detect the presence of scar, both small scars as well as large scars. Now, another example of this is this paper, which is a very complementary approach, because what these authors did is they used deep learning to quantify abnormalities in the motion pattern of the left ventricle, and they tried to see if this was able to detect the presence of scar tissue. And this is based on the assumption that areas of the myocardium with scar move differently compared to areas that don't have scar. So I'm jumping straight to the ROC curves here. And what this shows is that both subendocardial MI as well as transmural MI was detected with high accuracy in the study with 212 patients and 87 controls. So probably if you combine these approaches, you'll get even better results. So the final point, or the final use case I want to show you before I can come to my conclusions is this. So this is a patient with pulmonary hypertension. You can see the thickened wall of the right ventricle right here. And these patients typically have a very poor prognosis. And what we do now is we prognosticate these patients by measuring right ventricular ejection fraction. And if it's less than 40%, we know these patients will do relatively poorly. If it's above 40%, we know they do a little bit better. Now, why is this relevant? Well, because currently there are some new drugs that you can use to treat these patients. Let's see, I'm trying to visualize this while it's not coming up, so I guess I'll just tell you about it. So the drug Uptravi, which has recently been introduced, costs about $40,000 per person per year. And it would be great if we had better tools to measure or to identify patients who need this most versus patients who could perhaps go on a lower dose or be managed differently. And this is exactly what Bello et al. Tried to do, which is what I'm showing you in this paper right here. So what these investigators did is they analyzed motion patterns of the right ventricle. This is what you see on the right side of the slide. You can see these loops that represent the excursion of these particular locations of the right ventricle over the cardiac cycle. And what they did is they took these motion patterns in patients who died versus patients who survived, and they put this into a deep learning network that predicted outcome in these patients. And if we move to the right side of this slide, what you can see is that compared to conventional MR parameters, i.e. ejection fraction and strain, the machine learning motion analysis was better capable of identifying patients who would do relatively well in the short term versus patients who had a much poorer prognosis. In other words, patients who have a higher need for this expensive medication. So this is an example of how you could potentially use these advanced visualization and quantification techniques to better direct medical care to the right patient. So this brings me to my conclusions. Quantification is clarification, and it lowers the subjectivity. Machine learning has will enable faster throughput and extraction of more parameters with clinically acceptable imaging times and post-processing times. And this is going to be increasingly used for clinical management. There are many new tools in the toolbox, such as mapping, strain, and 4D flow, which are now entering clinical practice for good reasons. And there are a host of clinical use cases that I hopefully showed you. If you're interested in the indications for cardiac MR, this paper just came out today. It's the 2020 version of the Society for Cardiovascular Magnetic Resonance position paper on clinical indications for cardiac magnetic resonance. And many of the indications that I discussed in my presentation you can find back here. With this, I'd like to thank you for your attention and hand the presentation back to Kevin.
Thank you, Dr. Leiner, for a very engaging and very interesting presentation with a lot of incredible examples in a very short amount of time. I'd like to remind the audience that if we happen to have questions, please type them into the chat box. What we'd like to do is leave a little bit of time at the end to be able to answer any questions from our panel. And with that, what I'd like to be able to do now is hand over to Dr. Jonathan Leipzig, who's the chair of the Department of Radiology at Providence Healthcare at Vancouver, BC. Dr. Leipzig?
Thank you. You can hear me fine, I hope?
Yes, we can.
Great, wonderful. Thank you. Well, it's a privilege to be sharing the podium with Dr. Leiner, who's a dear friend and a tough act to follow. But I think we'll pivot nicely here from, really a forward-looking and also clinically integrated review of CMR and pivot now to coronary CT angiography. There's clearly tremendous technological innovation in the CT space as it relates to plaque characterization and quantification, facilitated quantification of plaque, non-invasive physiology from FFR CT and beyond. But I'm really going to spend the next 15 minutes or so to really try to make the case and to better define why I believe CTA should be the first-line test for patients with suspected chest pain or suspected coronary disease and new onset chest pain, as well as to really highlight any shifts in practice that may have occurred and that may be happening over time. My disclosures. So the reason I'm such an advocate, I believe, for CTA and why the European Society of Cardiology recently updated their chronic ischemic heart disease or chronic coronary syndrome guidelines to really provide a class 1 indication for coronary CTA is because I think it really helps answer in a very direct fashion the questions that are being asked when we're confronted with patients with symptoms suggestive of possible but not yet confirmed coronary disease. And to me, that question that's being asked is ultimately by the patient and by the referring physician, does the patient have or not have coronary disease, i.e., do they have atherosclerosis? Atherosclerosis is, of course, the disease that causes the overwhelming majority of incident myocardial infarction. In addition, if they have atherosclerosis, how extensive is it and how severe is it? And will it ultimately affect the quality or quantity of life? And is there something that we can do to actually improve both the quality and quantity of life? And so if we look at the traditional workup and management of patients with suspected coronary disease, and I understand this is a global audience, but if we reflect on the North American guidelines and the current guidelines in the United States, we know that there's been a traditional reliance on clinical assessment based on clinical adjudication of symptoms, which I think is obviously very important and a powerful way of assessing risk and pretest likelihood, but they're fundamental sex and gender and ethnic-based biases that are inherent when we clinically evaluate said patients. There are also fundamental limitations as it relates to stress tests. Stress tests will obviously play a continued very important role, as we saw just very elegantly from Dr. Leiner and is highlighted in the SEMR guidance. Stress perfusion MR, for example, is a tremendous tool as it relates to the adjudication of a number of clinical conditions, but I would posit to you that it's generally not the best test as it relates to determining whether or not the patient has coronary disease. And these tests are often very helpful to adjudicate further evaluation once coronary disease has either been excluded or once the extent and severity of coronary disease has been evaluated. And the reason I say that is we hear clinical histories that are somewhat atypical, but findings suggestive of possible or probable angina. And we do CT angiography following stress testing historically, and we would find cases where we'd find high-grade anatomical stenoses, or we'd find patients we would do CTA and we'd find patients that had absolutely no atherosclerosis, or we'd do CT and we'd find very minimal atherosclerosis, or we do CT and find very aggressive atherosclerosis with both high-grade stenosis and extensive non-calcified plaque with spotty calcification, positive remodeling, and low-density plaque. And we do these CTs, and I would posit to you that these patients have not only very different imaging findings, but a very different downstream clinical risk and should be treated very differently. And CT uniquely identifies these imaging phenotypes that really inform downstream clinical decision-making. Why do I think CT should really be the first-line test? I think that a lot of it has to do with the historic data that we've seen over the years that functional testing, I don't think confidently diagnoses coronary disease. Whether it's the National Cath Registry data published in 2010 by Manesh Patel and Pam Douglas, which highlighted that 63% of patients that go to the cath lab in the United States are not found to have stenotic coronary disease at the time of their invasive angiogram. Importantly, 82% of those patients in the National Cath Registry at the time had undergone non-invasive stress testing in advance. As well, if we imagine that we're not just looking to diagnose coronary disease, but we really want to safely treat patients conservatively on occasion, we really do need to make sure before we proceed with medical therapy that we've excluded, for example, triple vessel disease or left main disease. And if we look at data from Dan Berman's lab from Cedars-Sinai, now over a decade old, we know that from his data, over 101 patients with left main adjudicated stenoses, 44% of those patients had had nuclear stress testing before. 44% of those patients either had normal or mildly abnormal nuclear stress tests. So the only reason that we can be confident that the patient doesn't have left main disease following a normal or mildly abnormal nuclear stress test is only because the overall population, it's uncommon to have left main disease. But I don't think we can rely on that test to actually confidently identify the patient with left main stenosis in a way that we can with CT angiography. So the first reason I think that the algorithm and the diagnostic paradigm really should start with CT for the majority of patients with suspected, but importantly not yet confirmed coronary disease, is that I think it directly answers this first very relevant clinical question, and that is, does the patient have or not have coronary disease? We've learned from over a decade of data dating back to 2008, that the diagnostic performance of CT as it relates to the discrimination of anatomical coronary disease compared to invasive coronary angiography is superior to other non-invasive tests. That there's simply no better test as it relates to its negative predictive value, and the positive predictive value of CTA compared to the anatomical gold standard is also quite high. Now, many people will say, well, CT is a powerful tool, but can it really be safely applied across the patients that we're evaluating for possible but not yet confirmed coronary disease owing to the concerns regarding radiation? And while radiation dose always needs to be top of mind, I would posit to you that the evidence to date would suggest that CTA is a safe test when used appropriately. Here I highlight work from Jörg Hausleiter from the Protection 6 database, which he presented at the European Society of Cardiology in Munich back in 2018 and published in the European Heart Journal. What he did was he collected a number of sites to simply provide a sample and an audit of all the coronary CTs being performed at a number of academic and non-academic sites from across the globe, and audited the DLP and the estimated effective dose and compared it to the dose that was actually published in his Protection 1 data, Protection 1 registry in 2009. And what did we learn? We learned that the estimated effective dose from cardiac CT is roughly 80% lower than it was a decade previously. Now, again, that doesn't mean we should be doing CTA for screening. That doesn't mean we should be doing CTA without good clinical indication. But I think what it does mean is that if we adhere to best practice, we employ all the dose reduction strategies that are afforded to us by our vendor colleagues, and we are thoughtful with regards to the prescription of the scan parameters, that we can get a very accurate and diagnostically powerful tool test at an acceptable radiation dose. The third reason I think that CTA really has leapt forward as a very important tool in the workup of patients with suspected but not yet confirmed coronary disease is its powerful prognostic risk discrimination. Here I highlight on the single slide two very important points as it relates to the prognostic information provided by CT and uniquely provided by CT. This comes to us from the PROMIS database, a randomization of 10,000 Americans between stress testing, predominantly SPECT, and CT in the anatomical arm. And what you have here is on the x-axis time, the y-axis the percentage of patients with events. The lowest Kaplan-Meier curve on the left here in the CT strata are those with a negative coronary CT angiogram. What you can see is that the event rate in the setting of a negative CT is incredibly low, below 1% through 3 years within the PROMIS database. That's less than half of the event rate in the nuclear stress testing on the PROMIS. In addition, what is unique with CT is that we're able to identify these patients with non-stenotic atherosclerosis. We can identify them non-invasively, and what we've learned consistently from the CONFIRM registry and many other databases, and what we see here from the PROMIS randomized trial, is that patients with non-stenotic atherosclerosis have a threefold hazard for downstream events as compared to those without atherosclerosis, uniquely identified by CT. On the other hand, those with a mildly abnormal nuclear stress test as compared to those with a normal nuclear stress test, there's no risk discrimination between these two subsets. In other words, if you have two patients coming back to you in your clinic, one who had a normal SPECT and one who had a mildly abnormal SPECT, you simply have to revert back to population-based risk factors to guide medical therapy, because you simply don't know who's at risk and who, frankly, has atherosclerosis and who does not. In addition, when we look at the relative risk of a severely abnormal CT, you see that the relative risk is much more powerful than the relative risk of a severely abnormal SPECT test. The relative risk of a severely abnormal CT is tenfold. When you have a severely abnormal CT, these patients are at a markedly elevated risk. And that's a very powerful prognostic information that's provided by CT. As well, I would just highlight some data that was presented at the virtual ACC this year. This is by David Marin and Judy Hockman, as well as Harmony Reynolds from the ischemia trial, highlighting that the extent and severity of the anatomical disease by CT in the ischemia trial closely correlated with downstream mortality. On the other hand, the extent and severity of the stress testing abnormality exhibited no relationship with downstream mortality. So the anatomy on CT was strongly predictive of downstream mortality. Very important prognostic information identified in a non-invasive way from CT angiography. Now, I won't delve deeply, but clearly there's an entire field of plaque characterization, plaque quantification, and really refining risk further with CT-based measures of atherosclerosis. And I would highlight the upcoming SCCT guidance on this, on the evaluation of atherosclerosis on CT, and a real opportunity for us to extend beyond just the presence or absence of disease, or even the presence or absence of focal anatomical stenosis, to really highlight the opportunity to use CT as a non-invasive evaluation of the overall extent of atherosclerosis, the morphology of the plaque, the pattern of plaque, and the extent of plaque, all of which help us identify the patient at risk. Finally, as we transition and we assume that all of this is very powerful, we can predict risk, at the end of the day, patients really want to know, can this test help you as my cardiologist or as my internist to guide my clinical management in a fashion that will reduce my downstream event rate and improve the quality of my life and hopefully ultimately improve the longevity of my life. And I think what we know from the randomized data as well as multiple meta-analysis is that CTA-guided clinical decision-making appears to improve clinical outcomes. We've seen that from Scott Hart, where David Newby and his colleagues in Edinburgh randomized 4,000 patients between traditional care versus CT strategy, and they found that those patients who were randomized to a CT arm experienced a 40% lower cardiovascular death and MI rate than those who were randomized to traditional care. Now, you may say, why is that? Well, I think we've learned over the years from both Scott Hart and Promise, as well as many other large data sets, that CTA allows you to guide medical management rather than based on the population-based risk of having disease, actually guiding management based on the individualized presence or absence of atherosclerosis, as well as the extent and severity of that plaque. So instead of treating me because I have a risk of developing atherosclerosis, you can guide my therapy based on whether or not I actually have plaque. And not only does that allow for the up-titration of medical therapy to the right patient, but it also results in greater adherence to downstream medical therapy utilization and adherence to medical guidance, as we've seen in both Promise and Scott Hart, where there was increased utilization of preventative medications, really targeting also those with plaque, not just based on population risk of developing plaque, and also what we see over time is better adherence to those recommendations. So I think all of that evidence has really allowed us the opportunity as a field to understand that the value of CT is really in its diagnosis, its prognosis, and really guiding medical management. A very powerful tool that has led to the European Society of Cardiology to put forward a Class 1 guidance for the use of CCTA in a stable setting. Now, I think any talk on coronary CT in this era would be incomplete if it didn't reflect at least on the ischemia trial. And that goes beyond the scope of this talk to delve deeply into the ischemia trial, but I think we do need to at least appreciate how it may impact us with regards to our utilization of coronary CTA. And what I believe, and more importantly perhaps what Nick Curzon, a friend and colleague from Southampton, would suggest, is that I think the ischemia trial importantly highlights that optimal medical therapy is a very good option for many patients as an upline treatment strategy. But it also highlighted to us that there's no mortality benefit of revascularization in patients with stable symptoms, assuming left main disease and severe angina and reduced ejection fraction is excluded. But it also highlights to us that patients who undergo revascularization may derive a benefit with regards to reduction in spontaneous myocardial infarction, and also a significant quality of life benefit from revascularization as compared to optimal medical therapy alone. And importantly, ischemia was, of course, a trial that was looking not at the role of CTA or nor at the role of invasive physiology, such as FFR, but really trying to help us understand how non-invasive stress testing could guide revascularization. And I think what I've learned from the trial is that it probably doesn't inform revascularization over and above the anatomical disease, and certainly not to the extent that invasive physiology does. But what I do think it has also told me from a CT perspective is that CT plays an incredibly important role post-ischemia to really refine our understanding of the extent of severity of coronary disease, even in those patients we historically thought would have almost certainly have had extensive coronary disease. As we look at the ischemia trial, what we realized is that amongst those with moderate to severely abnormal stress tests, there was approximately 16 to 20% of patients that did not have significant coronary disease at the time of their CT. In fact, they didn't have a single stenosis greater than 50%. As well, CT played an incredibly important role in identifying those patients with left main disease, certainly very important before we consider optimal medical therapy rather than a revascularization strategy. We really need to carefully exclude, of course, left main disease. Moving beyond the ischemia trial, what else have we learned in the last year that I think will refine our utilization of CTA? We saw at the ESC, virtual ESC this year, that the European side of cardiology came out with guidance about the role of CTA in STEMI, providing a class 1 indication, incredibly important. And for those of us on this side of the pond, we saw a recent position paper coming out from a think tank that was held at the Heart House at the ACC, although not officially sanctioned by the ACC, that really highlighted that here in North America, we do need to make coronary CTA more available to the patients of the United States as well as Canada by enabling broader access, further education, and really enable the use of coronary CT in a more robust fashion for patients with suspected but not yet confirmed coronary disease. So I'll close with just final couple of slides, which I think really highlights what has historically been the limitation of CT, is that while it's been accurate, while it's been safe, while it was prognostic, and while it could inform medical management, it really couldn't allow us to really answer this final question, which is in the setting of a stenotic left anterior descending coronary artery, should the patient be revascularized or should the patient be treated medically alone? And what we know is that the decision around that cannot be made by anatomy, but really should be defined not by stress testing, but by invasive physiology, be it FFR or IFR. And we know that because the totality of randomized data to date would suggest that revascularizing patients with abnormal physiology allows you to identify those patients that will derive a benefit from revascularization. On the other hand, if you revascularize patients where they have anatomical stenosis, but the physiology is normal, they may in fact derive absolutely no benefit from revascularization. As shown here in the FAME2 data, we can see patients with abnormal FFR derive significant benefit from revascularization as compared to medical therapy alone. And similarly, in the Northern California VA, what we can see is that patients who are revascularized by physiology had a significantly lower downstream mortality than those that were revascularized by anatomy alone. And so I think the opportunities are there to grow, to learn from this continued signal for optimizing revascularization guided by physiology, and really an opportunity through the integration of not only anatomy, but physiology to better understand and refine which patients actually should or should not be revascularized. And what we know is that from the invasive and non-invasive data, that anatomy and physiology are not the same, that there's in fact an inconsistent relationship between anatomy and physiology, particularly in the 40 to 90% stenosis range. So we clearly need more, and whether that more is invasive physiology or non-invasive physiology, I think we need to really refine our understanding of patient-specific anatomy and physiology to guide revascularization. And to that end, with the adoption of non-invasive physiology from FFR-CT, we can finally complete the evaluation of not only anatomy, but anatomy and physiology to guide decisions around revascularization, which is the final question that needs to be answered that historically couldn't be answered by CT alone. But now, through the integration of FFR-CT, we have a tool that is highly accurate, as shown here from the Pacific data, as compared to the invasive gold standard, outperforming other non-invasive tests as it relates to invasive FFR, allowing us a non-invasive tool using CT and then computational fluid dynamics to derive an FFR CT roadmap that allows us to not only prognosticate, not only guide medical management, but aid with regards to the decisions around invasive angiography and the need for revascularization. So I'll close there, but I really do think that the coming year we'll see broader adoption of CTA for stable chest pain in North America. We'll follow our European and our UK colleagues for all the reasons that I highlighted over the last 15 minutes. Thank you again for the opportunity.
Thank you, Dr. Leipzig, for also a very engaging presentation and the opportunity to take a glance into the multiple benefits and facets that we can take a look at with CT. Now what I'd like to be able to do is potentially open it up for a couple questions that we have related to both CT and to MR. And for this, what we'd like to do is open it up to both speakers to be able to answer and field any questions that we've got. So again, I'd like to remind for anybody who's on the call, please type in your chat questions into the box and we can answer those as they come in. But perhaps a good place to start would be to reflect on the place that we're at in today's day and age, where COVID is affecting so much of the way that we manage our radiology departments and the tests that we administer to patients, wanting to perhaps minimize the time that they would be undergoing tests or minimize the amount of tests that would need to be done. I'm wondering, perhaps, and this is a question to both of you. I know Dr. Leiner touched upon this a bit in his presentation, but maybe in a little bit more depth. How has the COVID era really affected the prevalence within these modalities of CT and MR for cardiac analysis, really in-depth cardiac analysis tests to be done using some of these advanced visualization tools? Or are we still seeing or a kind of a reversion to using just the basic visualization of the imaging without some of the advanced visualization tools? Perhaps Dr. Leipzig, you want to take that first, and then we'll go back to you, Dr. Leiner?
Great. No, I would just I would echo those comments. I think that COVID has served as obviously a disruptive force in all of our departments, and primarily it's been negative, obviously. I mean, the loss of life and the disruption in care delivery. But it has made us rethink how we do things, and I think there are distinct advantages to CT as it relates to the directness of answering a lot of the clinical questions. And I think with advanced analytics, as we saw from Dr. Leiner, but also in the CT realm, whether it's, in particular FFR CT, not having to bring the patient back to our lab for repeat testing or for downstream stress testing or for an invasive evaluation. I think there's been an increasing openness for non-invasive testing, a single test to really provide an answer around anatomy and physiology and potentially avoid invasive strategies or aerosolized procedures such as TEE or exercise-based approaches. So I think it has really elevated the role of CT in our practice, and I know in the practice of many of my colleagues.
Thank you, Dr. Leipzig. Dr. Leiner, any further comment?
Yeah, well, what I can add to this is I try to stress the importance of doing parametric mapping, and we've been doing this already for a number of years in every patient who is referred to our practice with non-ischemic cardiomyopathy questions. So if the question is not related to coronary artery disease, we basically always do mapping in everyone, especially T1 mapping and extracellular volume quantification. If the question, if there's a reason to do edema mapping, we do this as well, which is obviously the case in suspected or known COVID or trying to image the sequelae of this disease. So we find it a very useful tool to help us to precisely quantify myocardial damage.
If I could,
Thank you.
Kevin, I would just say that I think what you're hearing from Tim, and it's why I think we we work so well together is what you're hearing from Dr. Leiner is really the focus in this era and beyond to really explore how to optimize which test to answer which clinical question. And I really took that from your presentation, Tim. Really powerful and really understanding why we're doing it and really trying to guide downstream decision making using imaging to do so, and really exploring all the data that's embedded in the imaging data set.
It's interesting because while there's an incredible amount of data that's captured within the imaging, we've heard statistics that maybe 10% of the actual imaging data that's captured is actually used. It would be interesting to see what we could try and do to drive greater adoption of some of these more advanced imaging tools, both in CT and MR, for advanced cardiac analysis. And in many geographies, we're still seeing that people are not necessarily using the breadth of potential tools that they could have at their disposal, either from the tests or from the advanced visualization tools that might exist for them. Any thoughts on how we can increase the usage or at least familiarity with some of these more advanced tools in practice?
Go for it, Tim.
Questions open to both, yeah.
Okay. Yeah. So this is a very good question, and I think the answer is clearly get it in the guidelines. Then generate evidence of added clinical value. So the objective of medical imaging is not necessarily to try to depict a certain pathology, but to support clinical decision making, to allocate treatment, to see how these patients should be managed or can be dismissed if there are no findings that mandate care. So the thing we need to do is we need to carefully show the added value of these tools, and increasingly this is being done, as I showed in my presentation. And if the evidence reaches a certain critical threshold, as we saw in Jonathan's presentation for cardiac CT, this will be incorporated into the guidelines, and then it really takes off because then you have to explain why you're not using it when the added value has been shown. So this is what we should focus on.
So well said. Really nothing to add to that. I think that's so spot on. We can't image for the sake of imaging. We really have to make sure that the data we provide is impacting clinical care in a thoughtful way.
With the prevalence of the use of AI within radiology today, I just saw that there was one question that actually came up on that came up in the chat, and I was curious. Maybe this would be a question best directed to you, Tim, because it was asked about MR. Are we seeing conflicts of results between AI and conventional MR parameters used in clinical practice?
Yeah, this is a very good question, and the additional thing we need to consider here is then if there is a conflict, who's correct, the algorithm or the reader? And I think there's a lot of activity in this space. Many people are developing algorithms, and they get better and better. And some algorithms have indeed reached the threshold of let's say inter-observer variability, which is basically what you need to reach in order for the algorithm to be considered equivalent to if either Jonathan or myself would read a cardiac MR case. And there's always small differences, but if they're small enough, then there's no problem. And I think we're getting at this stage, for instance, for left ventricular ejection fraction calculation. Now, the algorithms are so good that there is hardly any difference that's clinically relevant. Should there be a difference, however, or in any case, I'm of opinion that these are tools that extend the work of cardiac imagers and not replace that work. So I would use these tools, but I would still check the results. And I would not just simply copy the numbers that are coming out of these tools into my report. I would always check this, and I would urge people to do this. Although they're very good, they're not perfect, and sometimes they fail, and we need to be in control here. So,
Thank you, Dr. Leiner. Just in the interest of time, I'm going to do a short summary, and just I think we've learned from both of these presentations that cardiac and CT/MR are definitely growing in their importance, and hopefully will be continuing to grow in their importance in clinical guidelines, which will then hopefully enforce clinical practice as well. And that the usage of advanced visualization and perhaps AI tools as well can offer the potential to support both the clinical confidence and the speed of which we can do these cardiac procedures in terms, and as well as the depth. And to experience any of these capabilities, some of which we have on the IntelliSpace portal, which is to be launched at the RSNA, I welcome you to visit Philips at the RSNA 2020 to get a little bit of a taste of some of these capabilities in action. Thank you, Dr. Leiner, and thank you, Dr. Leipzig. And with that, I'd like to hand it back to Jack.
Thank you, Kevin. Again, to reiterate, on behalf of Radiology Today, thank you, Dr. Leiner and Dr. Leipzig, for sharing your expertise on these important and timely topics. And also, thank you, Kevin, for moderating, and to our educational sponsor, Philips Healthcare, for their support of today's program.
Thanks, Jack.
Thank you so much. Thank you very
Pleasure.
much.
Thanks for having us.
Thank you for trusting Radiology Today as your resource for the latest news and information for radiologists, radiology administrators, and technologists. We wish you a wonderful week ahead.